Welcome all of you to the 55th live webinar on orthopedic principles. Today, our guest faculty is Dr. Enrique Villalobos from Mexico City, Mexico. Dr. Villalobos is an attending orthopedic surgeon in National Institute of Rehabilitation at Mexico City. He's certified by the Mexican College of Orthopedics. He received his medical degree and specialty in orthopedics by the National University of Mexico. He has 2 fellowships, one in articular surgery and other in arthroscopy and sports injuries, also by the National University of Mexico. He's a sports medicine research fellowship by Tufts University in Boston, United States of America. He has a master's degree in medical science and currently is doing the graduation process for a PhD with a thesis on Autologous chondrocyte implantation. He's a member of the International Cartilage Repair Society as well. He created the cartilage chapter of the Mexican College of Orthopedics and was part of the board of the Developing Countries Committee of the International Cartilage Repair Society. In his private practice, he has to take care of the National Olympics Committee athletes and also has been the medical doctor of the first National League of Soccer teams at Mexico. Dr. Villalobos has developed with his group in the last 18 years the new all-arthroscopic technique for cartilage repair based on tissue engineering. So today, Dr. Villalobos is going to enlighten us on autologous chondrocyte implantation. Over to you, Dr. Villalobos.
Okay, thank you very much, Dr. Gapalan, for the invitation, and also thank you to Orthopaedic Principles platform to invite me to share this time with you. My name, as you hear, is Enrique. I'm going to talk about a matrix-assisted technique for autologous chondrocyte implantation. And during this webinar, I will try to explain you how we move this technology from the lab to the clinical setting, and how we follow all the evidence-based medicine to achieve this. As you know, chondral injuries is a very common problem, and we are going to see this kind of focal chondral injuries in our young sports population. And if an accident or a trauma happens when you are young and you are doing sports in your joint and nobody take care of that, your body is not going to heal the cartilage, as you know. And it's very well known that these chondral injuries could develop in 15 or 20 years post-traumatic osteoarthritis. So the first thing that we start to exploring in our research line is how frequent was this kind of injuries. As Dr. Gopalan told you, I work as an attending physician in the arthroscopy department of my institute. So we review 1,309 consecutive knee arthroscopies, and we found that in 61% of these knee arthroscopies sorry, that were done for any cause, there was a chondral injury of different grades, but in every 10 knee arthroscopies, in 6 of every 10, we are going to find this kind of injuries in low grade or high grade. And as you can see here, our population in which we found this kind of injury is young patients with an average of 37 years old. So we are worried about that is going to be like a problem in the future in a country as Mexico, that right now we don't have enough resources to treat every people that need a joint replacement. And comparing our results of the prevalence of chondral injuries to the prevalence that is published in other articles, we see that it's very similar, the prevalence of these injuries at the States, also what is reported at Europe, around 60% of prevalence of chondral injuries during a knee arthroscopy. In our population, the first location was patellofemoral joint, and the second one, the medial femoral condyle. So if the body is not possible to heal these injuries, and there is no drug, neither physical therapy that or injection that could achieve a cartilage repair tissue, the only option that we have, as you know, as orthopedic surgeons, is surgery. And in the term of surgery, we need to do chondral repair techniques that look to obtain a nice repair tissue. So we start this research line like more than 15 years ago. So the only option that we have 15 years ago to treat these lesions was microfracture technique described by Stedman. So after 3 to 6 years follow-up of doing this technique in our population, we presented our results at the American Academy of Orthopaedic Surgeons meeting. What we did was a cohort with patients that had microfracture technique for grade 3 or 4 chondral lesions of their knee. And we evaluate functional outcomes with a Lisholm scale and also visual analog score. And we also did MRI evaluation, as you will see. We analyzed 39 patients with the microfracture technique. We also treat concomitant pathologies, and we follow the same rehabilitation protocol that is described by Stedman. This is a microfracture technique that is very important to do the technique as is described, with these small holes with distance between the holes of 3 to 4 millimeters in a well-contained chondral injury. And as you will see, after the follow-up that we made around 57 months, we obtained a Lisholm score around 80 and also a Tegner score of 3.6. But what we consider most interesting is our also MRI results, in which the Mokart scale, that is a morphological scale to evaluate the quality of the tissue measured by MRI. It's a scale from 0 to 100. 100 is the best repair tissue possible. And we obtain 46 points in the Mokart scale in this microfracture group. And also we evaluate T2 mapping that measure the relaxation time of the water. And we can measure the native cartilage, the healthy cartilage, with a relaxation time of 36 milliseconds. And in the repair tissue, we have a higher relaxation time with 58 milliseconds. This is an example of our worst case of microfracture that we evaluate by MRI. As you can see, the Mokart evaluation is only 25 points. There is almost no repair tissue on the lesion. And measuring by MRI, you will see this color scale in which you can put a region of interest on the repair tissue, and there is almost no tissue there. And the measurement of this area is with higher relaxation time in milliseconds. And in the best case, by Mokart, with a better evaluation than the one at the left, is 55 score. But there is a lot of bone edema, and T2 mapping is a little bit better than the one at the left, with relaxation time lower, with lower values, but not similar to the native cartilage yet. And this is the final conclusion of this cohort of the microfracture group. As you can see on the black line, this is the Lisholm score through the time. And once the patients achieve the 5-year evaluation, after that, a decrease of the Lisholm values started, and an increase of the pain also started. So it's like a good short to medium term technique, but after 5 years, we will have an increase of the symptoms that the patients have. So our results are similar what is published by Knudsen, Saris, and Kohn in terms of failure rate, clinical results, and level of sports activity. We found a decrease in function and pain relief with a faster progression after 5 years, inferred by the stepper curve in our graph results. Also, we found low Mocart values and high T2 mapping values. That means inferior quality of the repair tissue compared to native cartilage. So that was what we get with the considered gold standard technique, that is microfracture. And as you will understand, we were not happy with, I was not happy with those results. So in that time, like more than 15 years ago, we started hearing about tissue engineering techniques, about autologous chondrocyte implantation described by Bridberg and Peterson. And I will explain you how does it works. In this kind of techniques, we need to, if you have a chondral lesion on the knee, you need to take a small biopsy in which you will isolate the chondrocytes at a GMP lab, and you will put those cells on culture for 6 to 8 weeks, and then you can seed those cells in a scaffold. And in a second surgery, we will do arthroscopic implantation of that scaffold with the cells that were cultured from the patient. This is how does it works, and it's a nice tissue engineering application available in orthopedics. As I told you, this technique was first described by Bridberg. The first generation was just a cell suspension that we needed to put it on the knee with an open approach, as you can see. And we need to take a periosteal patch to cover those, to cover the defect, and to put a lot of sutures that make the technique very difficult, and we spend a lot of time with that. We decide not to start with that technique. We prefer to move to the next generations of ACI, that is matrix assisted autologous chondrocyte implantation techniques. There are several reports about that. And the main idea is that we prefer to use a scaffold for setting the cells, and that will make easier the implantation technique. We also were worried about the fixation of the scaffold. We visit Professor Ergelet at Switzerland to see the results with this kind of fixation. And finally, as you can see, we decide to use an anchor system fixation with a small biodegradable anchors on the subchondral bone, just to be sure that our scaffold was going to be on place through the time. So taking this in consideration, as I told you at the beginning of my talk, we start a long way from the lab to the clinical setting to develop this new technique. So the first thing, when you have an idea and you want to move to the clinical setting, you have to start with preclinical studies. So that's what we have done on the last 15 years. First of all, we start with in vitro studies and experimental studies, as you will see. This is my mentor, Dr. Clemente Ibarra, that has the opportunity to spend more than 5 years at the United States of America in Boston and New York Hospital for Special Surgery with Professor Bacanti, which is a pioneer of tissue engineering techniques. And he, my mentor, started these trials in atemic mice. And once he came back to Mexico, we start doing this matrix-assisted autologous chondrocyte implantation technique, this MASI technique, in a horse model. We choose the horse model because it's a big model and makes us possible to do it by arthroscopic implantation. As you can see in this, I hope you can see this small video in which there is the scaffold with the anchor fixation with a PDS suture. And in this article that is published on the Arthroscopy Journal, we demonstrate the viability of the cells once the scaffold was implanted in during a knee arthroscopy with the use of water and also with the use of a pump. So we proved that there was no cell detachment because once we implant this scaffold into the horse joint, some minutes later, we take it out and move this scaffold to the lab to evaluate cell viability. We demonstrate that with this in this paper. At the same time, this was my orthopedic thesis to be graduated. In this study, we did an animal experiment in pigs. And what we did was to do surgery to the knee joint of the pig. We made 2 injuries. In one knee, on the left knee, we put nothing. We just do an osteochondral injury. And on the right knee, we did the MASI technique. We did cell culture, and in a second surgery, we did the implantation. So 4 months later, we sacrificed 8 pigs, and we evaluate the results of the both areas by MRI, by macroscopic appearance. And this is very nice picture in which you can see how there is new cartilage on the area of the defect. And we evaluate by histology, in which in at least 5 of the 8 specimens, we found a hyaline-like cartilage. And also we did a electronic microscopy evaluation in which we could find chondrocytes with a nice activity. So we were happy with those results. So we moved forward to the next step. We asked to the government for funds. I work in a public hospital, and we obtained those funds to build a GMP lab located in the operating room area that we have in our hospital. So this lab right now is located like 4 or 5 feet from my arthroscopy suite. So in this area, we start doing cell culture for human use. And having all that together, we start enrolling patients for our pilot study, in which the main objective was to prove safety and short-term efficacy. So our inclusion criteria was patients 18 to 15 years old with ICRS grade 4 chondral lesion, 1 to 4 centimeters square. We need that the joint has to be on a neutral mechanical axis, or at least no more than 25% around the neutral line. In case that our patient doesn't have this nice alignment, we have to do an osteotomy during the first surgery of the cartilage biopsy. Also, the knee has to be stable, or if it is not, we need to do ACL reconstruction. And it was also an inclusion criteria to have meniscus tissue, at least 50% of the meniscus tissue. So we were looking for this kind of well-contained chondral injuries. And this is how we make our technique. During the first surgery, we observe the chondral injury, and with the use of a curette, we make a nice shoulder injury, shoulder contained injury. And we proceed to do a cartilage biopsy. We took cartilage from the notch using this mosaicplasty device of 4 millimeters of diameter. We took 2 or 3 osteochondral plugs from that non-weight bearing area, and we sent that cartilage biopsy to our lab that was in the same operating room area. So our scientists of the lab did the cell culture for the next 6 to 8 weeks. At the beginning, they have just few cells in that biopsy, like 50,000 cells, but we put on culture those cells. They need to change the serum every 3 days, and they did 2 passes of the cells until they have almost 18 million cells. And that was what the protocol said, that was enough quantity of cells to be implanted. So after we achieved this quantity of cells, we scheduled the next surgery, and we made the implant construction. As you can see in this video, what we used was cells in monolayer with a PGA scaffold and a pellet of cells above the scaffold. So with the monolayer cells, we encapsulate our scaffolds. That's why we name this technique matrix cell encapsulation technique. And that helps not for protect the area of cells with more density that it's here, covering or encapsulating the scaffold with the monolayer. We did a cell viability evaluation before implantation and after implantation, in the case that sometimes there were some scaffolds that were not used during the second surgery. So we wanted to evaluate everything. And this is how we make our all arthroscopic technique. As you can see on the right, there is the scaffold, and we are pulling the sutures that are on the anchor. And as you can see in the left video, the scaffold is going through the joint. We use a transparent cannula, and we put this small around 1 centimeter diameter circular scaffold in the joint, and we can repeat this procedure 2 or 3 times depending on the size of the lesion. I hope you can see this video in which this is an example of our scaffold. This was a small chondral injury, but in case it was bigger, you can use 2 or 3 of these circular scaffolds with a PDS suture. And finally, we do arthroscopic knots. Remember that we are arthroscopic surgeons. We like shoulder surgery, so we put our knowledge on those kind of techniques for doing this implantation surgery 100% arthroscopic. So there is another video that demonstrates how is made the scaffold implantation. First of all, we put a bioabsorbable mini anchor on the subchondral bone with PDA suture, and then we can put the scaffold through the joint with this technique. This is an example of the chondral injuries that we treat during our pilot study, 1 to 2 centimeters square grade 4 chondral injuries in a weight-bearing area of the condyle. And in all the patients, we ask them to do a second look evaluation 1 year after. Was very consistently our findings. We found cartilage repair tissue, looks like maybe Yalin-like, but we were not allowed in this case to do biopsies because the ethical committee didn't allow us to injure the repair tissue for research purposes. So we did only macroscopic evaluation with what we consider nice results. So we published our first results also in arthroscopy in the year of 2014, demonstrating that we have a new technique, all arthroscopic, that was safety, and also that was that has nice clinical efficacy. We were invited to publish our technique in this book of the International Cartilage Repair Society, in which we show our all arthroscopic technique for chondral injuries located at the femoral condyles. And also we develop our technique to treat patellar lesions with an all 100% arthroscopic approach. As you can see here, this is a patellar chondral lesion. And then we use a curette to obtain a nice, well-contained injury. And we did a retro drilling technique with these pins, and we use a shuttle device that the name is Chia percasser, from outside the joint to inside the joint through the cannula, so we can put in this shuttling device our scaffold outside the joint and move through the joint into the defect, achieving this result during the implantation surgery. And these were our second look results in this case, with nice tissue, nice repair tissue in the area in which 1 year before was not cartilage there. After we have this new technique, following the orthopedic principles, following the evidence-based medicine, we need to move forward to the next step, that was to compare our new technique with the considered gold standard treatment, that was microfracture. So we asked for the government for new funds to do a randomized control clinical trial. We were this clinical trial was accepted, was also registered at clinicaltrials.gov, and we start this trial results. The purpose of this randomized clinical trial was to compare clinical evaluation and T2 mapping results between arthroscopic matrix encapsulated autologous chondrocyte implantation technique. We are going to call this technique just AMESI, and microfracture technique for the treatment of articular cartilage lesions in the knee. This is a level of evidence once study. We include 50 patients, 18 to 50 years old, with symptomatic articular cartilage lesions, 1 to 4 centimeters square, grade 3 and 4, that were randomized between AMESI or microfracture. We also treat concomitant pathologies that is very common in this scenario. And both groups follow the same rehabilitation protocol. This is a microfracture technique as was described by Stedman. For chondral injuries at the patella, in some cases in which microfracture was not possible, we use a retrodilling technique to do the bone marrow stimulation, just in few cases. And for the AMESI group, we use the technique that I already described. Just a quick reminder of the patellar technique that is kind of difficult to explain. As you can see here, there is the lesion. Number 2, we start doing a retrodrilling technique to put from outside to inside 2 pins located side of the lesion. And with these 2 holes, we put inside the joint a shuttle device that the name is Chia percasser through a cannula. And this Chia was take it out of the joint through the cannula, and outside the joint, we put our scaffold with cells with the PDS suture through the scaffold, and then we retrieve those sutures to the joint, and we obtain this implantation, arthroscopic implantation of our scaffold with a knot on the dorsal side, knot of the sutures on the dorsal side of the patella. And this is the second look 1 year after. So we did prospective clinical evaluation, pre-op. These are the prompts that we evaluate. We also like to do a structural evaluation with T2 mapping. T2 mapping, it's a nice technique to know how is the repair tissue. We put a region of interest in the MRI evaluation on the repair tissue, on the basal layer, superficial layer, and a global evaluation of the repair tissue. And also we measure the values of the native cartilage to make comparisons. We also did second look arthroscopy in most of the patients using this cartilage repair assessment evaluation tool described by the ICRS. Our demographics that we had were very similar in both groups. Our baseline values with no difference between groups, thanks to randomization. And this is our consort picture, in which, as you can see, we have 24 patients per group. At the end of the second year evaluation, we complete 20 patients per group with 2 treatment failures on the microfracture group. These are our clinical results, in which you can see both groups had an improve from the baseline values, but with no difference between them. So we have no difference, significant difference on the 2-year evaluation. But in the structural evaluation, we found significant difference favoring AMESI with lower relaxation time of the repair tissue on the AMESI group against the microfracture group. Also, by the second look evaluation, there was a statistical better outcome after AMESI implantation. And this is an example of what we, in the outcomes that we have difference, T2 mapping on the AMESI group with nice repair tissue, with T2 mapping values getting closer to the native cartilage values, with this kind of second look macroscopic evaluation, in comparison with microfracture that many times has subchondral bone edema, with T2 mapping values higher than native cartilage T2 mapping values, and with this kind of macroscopic appearance. So I was very convinced that this technique has better structural outcomes, and maybe we need to wait more years to have a clinical difference between these two groups. So there were two failure cases on the microfracture group. And we found comparable clinical results in both groups as reported in Knudsen and Saris trials. We have a higher failure rate at microfracture group as T2 mapping evaluation was better for AMESI than microfracture as observed in other studies. Better results for AMESI than microfracture were observed at second look evaluation, also similar to the reported by other case series. AMESI and microfracture at 20 months follow-up have similar clinical results, but in the structural outcomes, AMESI had better T2 mapping and macroscopic ICRS scores than microfracture. This was the first randomized clinical trial that compared these techniques in a 100% arthroscopic approach, with an 100% arthroscopic approach that make comparisons more fair. Weakness is that it's a short follow-up. We need longer follow-up to know if better T2 mapping, better second look evaluations will translate into clinical differences. We published our results of this part of this randomized clinical trial at 4-year follow-up at cartilage, in which we continue observing structural superiority of AMESI technique. And this is an example of nice T2 mapping evaluation with our matrix-assisted chondrocyte implantation technique. We used to do serial evaluation prospectively in each of our patients that are in the study. And as you can see here, this is the pre-op evaluation with almost no cartilage. And if we put a region of interest there, we are going to have a high relaxation time values. But then after 3 months after implantation, you can see here how is the anchors inside through the subchondral bone that we use to the fixation of the scaffold. And take a look how it's going to change the color of the repair tissue through the time. That means that the implant is going through a maturation process that at 24 months has nice T2 mapping values close to native cartilage values in the AMESI technique. So finally, once we finish this randomized control clinical trial, I consider that we have enough internal validity, but we need to show and to demonstrate that this technique could have external validity. So we did another research proposal for a multi-center study to be developed in my country, not only in my hospital, also in the metropolitan area. As you know, Mexico City is almost 13 million people city. So we have many hospitals in this area, and developing this kind of technology is that I think that we don't need to do a GMP lab in every hospital, in every corner, in every institute. That will be very expensive. What we want to prove that having a validate GMP lab at the city, we can move these tech hospitals in an area around the lab in a safety and efficacious way. So I'm happy to show you our results of this multi-center investigation in Latin America that was just published 3 weeks ago on cartilage. And I think this is the main result of our what we call minimum biosecurity parameters recommended for matrix autologous chondrocyte implantation technique. We think that was very important to publish our parameters, because we find that many techniques that today are commercial available around the world for this kind of technology, it's kind of difficult to find their biosecurity parameters. They used not to publish in scientific articles, maybe for commercial reasons, but we have interest in this technique, so we were happy to share our biosecurity parameters so you can follow if you want to do this kind of technology your own lab. This is our experience in which you have to take care about the storage, cell culture, constructs transportation from the lab to hospitals in terms of time, temperature, humidity, cell viability, which screenings do you have to do. So this and also we publish our results in this multi-center setting with 30 patients with our PROMS evaluation, with nice improvement in all the knee scores at the final follow-up. And also we put our structural results by T2 mapping and second look arthroscopy, as you can see here. So this study suggests that by P minimum for a MESI, favorable clinical imaging and second look scale multi-center study in Mexico countries. As a conclusion of my lecture, in terms of our technique, we think that is a technique simple and reproducible for trained arthroscopic surgeon. we have predictable results up to 36 outcomes as expected, short term with outcomes. We have a statistical we have conclusions. I want to thank all the team that we multidisciplinary team that is needed. We have the tissue engineering and cell therapy biotechnology lab with Director Yo, and also the orthopedic sports medicine arthroscopy and our morphology department and imaging department. So I want to thank everybody for this research that we have done on the last 15 years, in which I have been just part of that. And I'm happy in this moment to share with you. So thank you very much for your attention, and I will be happy if there is any question, if there is time for that, I'm ready for that.
Thank you, Enrique. That was a brilliant presentation, and you have looked into what is the current status of autologous chondrocyte implantation. So the technique that you described, is it different from the MASI, or it is a refined version of the MASI?
The question is if it is different than MASI?
Yeah.
Okay. Yes, I think that the main difference that we have is that that we are doing an encapsulation of the scaffold. And the reason for doing that encapsulation is that we wanted to do an all arthroscopic approach for the implantation. I have the Professor Bridberg at Sweden and Professor Tom Minas at the States. And when I saw this technique, they used to do, maybe some years ago, a big open approach to treat, for example, patellar lesions. So as we are a sports medicine department, we tried to do some modifications in the MASI technique to make it possible to do it arthroscopically. So that's the main difference, that we encapsulate our cells so we don't want, and that allows us to use the flow of water during the knee arthroscopy, and we prove that there is nothing happening to the cells during this kind of implantation. But it's definitely is a matrix-assisted autologous technique what we are reporting.
Okay, so the encapsulation allows you to do an all arthroscopic technique. Is that the final word, right?
Yes, correct.
Okay. The other one is, are there enough randomized controlled trials, that is level 1 evidence, for this particular procedure compared to the previous generation ones? Do we have many RCTs?
Do we have many RCTs?
Yeah, comparing the encapsulated one to the previous ones.
Yeah, that's a nice question, Dr. Gapalan. Right now, we are just finishing our next paper that we are going to send it maybe this week with our medium to long-term results. So in the discussion area, we just made a systematic review of the literature, and there are only up to date 6 randomized control trials that publish the results between matrix-assisted autologous chondrocyte techniques and microfractures. Those are the studies from Bridberg, Saris, and a group of Germany with the Codon technology. But they have reported just medium-term results. The longer follow-up is 5 years. They have found clinical superiority in some subscales of CUS with the MASI techniques, and different structural outcomes, not as, I think we have structural outcomes with very consistent superiority of the MASI technique, but in previous studies, they have focused not so much on structural outcomes, more on cal, because they need that for FDA approval and approvals at Europe to be superior than microfracture on clinical setting. And so there are just a few RCT studies, and with the MESI, the one that we are going to publish soon is going to be the longer follow-up that we have up to date.
And in the 6 RCTs that you have mentioned, what has been the trend? What is the trend? Does MASI has a real superiority, or it's just a clinical superiority? I mean, just a very marginal superiority.
Yeah, that's a very good question. We found in maybe in 2 or 3 that the superior and not statistical significative. On the other, but the superiority exists in favor of MASI techniques. On the other side, we are start using other kind of outcomes based on patient response rate that I want to talk with you about that, because I'm sure that you know a lot about that. And with this patient response rate outcomes, we found, and in most of the studies recently published, found that MASI had a higher responder rate at midterm. At 2 years follow-up, responder rate between MASI and microfracture is very similar. In our results, microfracture is a little bit higher, the responder rate at 2 years follow-up, but at 4 and 6 years follow-up, there is a difference with a higher responder rate in the MASI technique. So it looks like we are looking for different ways to understand the outcomes, not only with the use of a significant difference, but in my personal opinion, after these 15 years of research, I really think that MASI techniques allow us to have better structural outcomes. I have no doubt about that. I have seen in every second look arthroscopy and in every T2 mapping evaluation, but maybe we longer follow-ups to know if that is consistently on clinical setting that for the patient.
Okay. The other question would be, have you found a correlation between the second look arthroscopic biopsy and the T2 mapping MRI?
Nice question. Yeah, we're searching for that kind of correlations in our current. Yes, we have found good correlations between structural outcomes. a nice or good correlation between, for example, what we had as a structural outcome between second look arthroscopy and T2 mapping, between second look arthroscopy and MOCART evaluation. We have good correlation between T2 mapping and MOCART evaluation, but we don't find correlations between clinical and structural outcomes. But there doesn't. Hello?
Enrique, yeah, I think your connection was interrupted in between.
Yeah. Hello, I'm here. Sorry.
Yeah. I think there's a small issue with your network. Okay, Enrique, so I think that's all the questions that we have for today's session. And we have had a fantastic session with you. And the lecture is going to be archived and it's going to be available for the world to watch within a few minutes. And thank you once again for being with us. It has been a pleasure to be with you on this evening. And we look forward for more from your side. Thank you very much.